Good evening, and thank you for joining. I'm your host and moderator, Subhash Banerjee. I'll be shortly joined by my co-moderator, Dr. Mehdi Shishibur from Case Western Reserve, and I have the distinct pleasure of introducing this topic on this Thursday evening, 9 p.m. Eastern and 8 p.m. Central webinar on drug delivering therapies for lower extremity peripheral arterial disease. And I bet you this will be a worthwhile time spent with us because the topics that we have for you to discuss by our panelists and speakers is going to take you a whole lot of time to discover and be enlightened on. So I think in the era of webinars, when things are getting a little boring and stale, we have chosen this topic because this is the upcoming science that is going to change our field of PAD, along with case examples and best practice discussions that I'm sure each one of you will enjoy. So some of the mundane part from me, from the foundation, just to tell you that it'll go for an hour, approximately 10 to 12 or 15 minutes of discussion and presentations. And of course, you are free to use the chat function, which we will monitor very actively. And don't be shy on asking provocative questions. These are experts who need to be stumped. And I think with your support, I'll be successfully be able to do that. This is a CME webinar, and there are some aspects of the webinar, apart from the key learning objectives mentioned on the slide, that would be off-label. And there's a 1 hour of AMA-PRA credit, a level 1 credit allowed for each one of you, which I will share the link that where you can actually claim those credits. First and foremost, the three esteemed faculty who have graciously donated their time to share their thoughts on these very interesting topics. Start with Dr. Alyssa Alton from Yale School of Medicine, Dr. Drew Klein from Piedmont Heart Institute, and Dr. Sahil Parikh from Columbia University Medical Center in New York, New York. And of course, my esteemed colleague, Dr. Mehdi Shishibur from Case Western, and myself, Subhash Banerjee from University of Texas Southwestern in Dallas, Texas. This webinar, apart from being CME, as I mentioned, there will be some off-label content, but it has been generously supported by our three sponsors, without whose support and promotion, this would not be possible, and that is from Abbott Vascular, Boston Scientific, and Medtronic. At the end of the webinar, you can either log into the site, which is also on your invitations and also can be obtained from the cvinnovations.org website to claim your credits. And this needs to be done before December 22nd. And again, a announcement for the December 7th, 2021 webinar on structural heart disease, the science behind a valve designed for life, sponsored by Anteris. And as you will see, that we have deliberately chosen topics that will probably make this hours very, very worthwhile for each one of you. Without further ado, let me turn it over to my dear friend, Dr. Sahil Parikh. And his talk is to talk about drug delivering technologies, especially paclitaxel and rapamycin. And while I unshare and he shares, I can tell you that he has a history on this topic. And I cannot think of anyone else that I've heard in the recent past who can speak on this area and also answer our questions. So Sahil, the floor is yours, and please take it away.
Subhash, you're too kind. Thank you for the kind invitation. I'm delighted to be here and to talk about one of my favorite topics, which is vascular drug delivery. I've been tasked in the next 10 minutes to talk about specifically the features of paclitaxel and sirolimus for the treatment of PAD. The context was in the setting of DCB, but sort of going to broaden that a little bit because there's first principles that I think are important. These are my disclosures, but really the most relevant disclosure is, as Subhash mentioned, I've been working on drug delivery for close to 30 years. I was lucky as an undergraduate to work with Elazar Edelman when I was a Harvard undergrad and he was at the MIT Biomedical Engineering Center. We are still collaborating now almost 30 years later. And this was the first circ paper we worked on together when I was his undergraduate student. So for me, vascular drug delivery is often expressed mathematically as a series of differential equations, because I grew up as a vascular biology engineering student in Elazar's lab. But I think I'd like to sort of bring it back to clinical reality, and sort of make a few key points that are germane, not just for drug-coated balloons, but all vascular drug delivery. So it starts by understanding that the vascular response to mechanical injury specifically is quite stereotypical and is consisting of thrombotic, inflammatory, and proliferative phases, followed by extracellular matrix elaboration and remodeling. We have come up with different therapeutic targets in each of these different phases of vascular injury and repair, but it's this proliferative phase that has been the target of local drug delivery in the form of drug-eluting technologies. The principal pharmacotherapies that have been applied locally have been sirolimus and its analogs, which, as you know, binds to the FKBP12 binding site, and inhibits cell cycle progression. And then there's the taxanes, or paclitaxel being the archetypal drug, which prevents microtubular assembly and mitosis. And these are both cell cycle and anti-proliferative agents that have been effective in the treatment of intimal hyperplasia. Everybody, if you remember back over a decade, remembers that the sirolimus-eluting stent, or Cypher, and the first paclitaxel-eluting stent, or Taxus stents, were clinically approved for application in the United States and globally because they inhibited target lesion revascularization by inhibiting intimal hyperplasia. It was felt to be a no-brainer that these technologies would then be adapted for other vascular territories. But to our chagrin, sirolimus-eluting stents, shown on the left, and paclitaxel-eluting stents, while more effective than their sirolimus counterparts, were nowhere near as effective in preventing TLR in peripheral arteries. And it became clear that we didn't understand the biology of drug delivery in the periphery enough that we could recapitulate our success in the coronary. So let's go back to basics for a minute, and let me geek out so that we can understand what can we do to improve the efficacy of these products. First, it's critically important to recognize that adluminal drug delivery from within the vessel requires diffusion across the artery wall, and can be achieved via drug-coated stents without polymers, aka Zilver, drug-eluting stents such as Eluvia with sustained release polymers, drug-eluting balloons, which are infrequently used, that are agents that weep drug, although now with perivascular drug delivery technologies like the bullfrog, this is a new technology again. And then the dominant modality, which is drug-coated balloons, which leave a slurry of an excipient bound to the drug on the inner lining of the luminal interface to allow for diffusion. And the therapeutic effect is directly proportionate to how long we can keep the drug in the artery and at what concentration, usually a therapeutic concentration of 1 nanogram per milligram of tissue. So how does this look? If you gave drug via a drug-coated balloon, you're administering a massive bolus of drug, which decays away through the body's own natural clearance mechanisms over time, but typically gives you an area under the curve that you see here, with an effective duration of tissue residence of up to 2 or 3 months. With a drug-eluting stent, this can be extended far further because of the sustained release polymer on the indwelling scaffold. And in either case, what one wants to achieve is an area under the curve. In other words, a concentration times time that is adequate to inhibit the proliferative phase of intimal hyperplasia that we talked about in the first slide. The way one can achieve this is by first picking drugs that are hydrophobic and highly avidly bound to the non-specific binding sites in a tissue. Take, for example, a hydrophilic drug like heparin. Even if it's given symmetrically about the clock face via a stent, it doesn't bind avidly because it's quickly diffused through the vessel and doesn't stick, if you will. Hydrophobic drugs tend to have a much higher affinity for binding non-specifically to the artery. More importantly, the specific drugs we're talking about, taxanes and limus agents, have binding sites on receptors that are distributed across the media of the blood vessel. So imagine on the left is the intima, on the right is the adventitia, and this is the media of the artery. there are differential distributions of tissue binding sites for the specific drugs, which allows there to be a concentration of drug that exceeds the bulk concentration of drug in tissue. In other words, if you put paclitaxel in a solution of 1 nanomolar and soaked an artery in that tissue, you would get a concentration of almost 30 nanomolar in the tissue because of this receptor binding distribution. And this is different depending upon which drugs you're talking about. Rapamycin or sirolimus has a differential drug binding site across the media compared to paclitaxel. And so you get differential binding of drug across the media. You also have differences in bulk drug deposition versus retention as a function of binding sites. And theoretically, if you can get the drug there, rapamycin in different experimental paradigms has higher binding avidity and should be retained better. You just got to get the drug to the right target tissue. This is also a saturable phenomenon. So there is a certain point beyond which if you give more drug, it just won't stick because the binding has already been saturated. It turns out that different inflammatory states can change this receptor binding distribution. For example, taxanes in a cholesterol model shown in pink, I'm sorry, in blue, will have a rightward shift of the receptor binding away from the media, from the lumen media interface. And limus drugs tend to have less of that effect in the inflammatory state, as would be stereotypical of atherosclerosis. And finally, lipid and calcium are both diffusion barriers for drug getting from the lumen into the artery. And so the more lipid there is, the less drug you're going to find in the artery because it's harder for it to get through that diffusion barrier into the blood vessel. We've seen this famous figure from Finelli showing that the more calcium there is, the less effective drug-coated balloons are. And if you take away calcium, you can more effectively bind drug in the artery. This was experimentally done in an animal model in Elazar's lab. It's the same first principles as the lipid data that I showed you. So finally, if you put it all together, and in the context of paclitaxel-coated balloons, different drug-coated balloon formulations have differential drug uptake and binding, and therefore efficacy. This is nice work done by my colleague here at CRF, Juan Granada. If you take different drug-coated balloons, take here Lutonix, Ranger, and Impact Admiral, they have differential drug binding and uptake. And you can see that some drug-coated balloons have more drug uptake and area under the curve than others. And this roughly correlates with their clinical efficacy in terms of reducing intimal hyperplasia and target lesion revascularization. So I think that some of these first principles, when assessed, clearly predict therapeutic efficacy. So how do we develop an effective drug-coated balloon? We have to deliver a lot of drug in a short time. We have to distribute it within the media very quickly. We need to maintain therapeutic drug levels for at least a month, and I would argue the longer the better. We must allow for rapid healing. We want to inhibit the need for antiplatelet and antithrombotic therapy, and we want to avoid off-target or non-target effects. So one of the ways to do that is to go from the early phase of crystalline drug, both paclitaxel in this case and also sirolimus, getting away from crystalline drug and moving to more amorphous or biomodified coatings. And you can see that there's differential drug uptake based on the different coating morphologies. And then there are ways to do that to sirolimus that can overcome some of the early difficulties we had in getting therapeutic concentrations of drug in the artery. And the particularly interesting concepts currently in clinical trials are the use of nanoencapsulation of the limus agents to achieve therapeutic levels of drug. And this, for example, is stereotyped by the Magic Touch device from Concept Medical, which is currently going clinical trials for both coronary and peripheral applications outside the United States. So it's pretty clear that as we've evolved drug-eluting technologies, we've gone from a linear slope that's relatively steep for length to restenosis to a much shallower and almost flat slope now with the use of drug-eluting technologies. And that's the clinical argument for why we want drug-coated technologies in our armamentarium. I hope that some of these first principles that we reviewed will help you understand how these technologies are going to evolve over the next, let's say, 5 years. Just to thank Elazar Edelman for teaching me everything I know about drug delivery. This is the Edelman family tree as of about 10 years ago. And I was relatively early on that family tree, and I'm delighted to be still collaborating with him on some of this important research. Thanks very much.
Thank you, Sahil. You know, I don't want to brag, but this is the best 15 minutes I've had on this topic for a very, very long time. And I think you have done justice to my introduction saying that this would be a time worth spent, because it will take a lot of time to review these topics and actually understand it. And now having this foundation, and many of us will actually dive down into some part of the literature. You know, there is a question from the audience. I'll take that first, and before going to our panelists and myself, the question is: does stent scaffolding and or polymer impact the efficacy of anti-restenotic drug? And that comes from our esteemed colleague, Dr. Bo Hawkins. So he asks you a tough question here.
Yeah, so Bo, the two very important questions, and I'll take them both in sequence. So first, one of the big differences between small diameter and large diameter arteries is the distance between stent struts from one another. So the drug will diffuse from the source, which is the strut and the polymer, and will move both longitudinally and radially and spread. And so if you don't have enough drug between the struts, you'll have hot spots of drug and cold spots. Forgive me, Subhash, if I can share my screen again. I'm going to show a slide that illustrates that point, which I glossed over, but I think it's an important concept. So if the struts are too far apart, you won't get enough drug in the artery and you'll have a nidus for restenosis. So take, for example, here, if you have struts uniformly distributed about the clock face, but the drug doesn't stick, there's not enough drug between the struts. On the other hand, if it is uniform and you have a sticky drug, you'll have plenty of drug concentration 360 degrees around the clock face, which would be different if you had an asymmetrical stent design where you get hot spots here and cold spots here, and this could be a nidus for restenosis. So the first thing is, yes, it's important that when you have a drug-eluting stent, there's relatively uniform drug deposition from the struts, and that they're close enough together that they will have an artery to make sure there's no cold spots. That was probably one of the first problems when we took coronary stents and tried to apply them to peripheral arteries that were 3 or 4x in diameter. So that's one. The second thing is, does the polymer affect the drug? And the answer is not, unless it does not adequately deliver the drug for long enough. Polymers are very, very easily and more carefully tuned to provide drug concentrations that are quite steady. You can pretty much set a step function of drug concentration if you know how to tune your polymer. And so if it's done right, the polymer actually, it makes it a lot easier. And the challenge, on the other hand, with drug-coated balloons is the excipient, getting the right secret sauce, if you will, of excipient and drug so that it binds to the balloon, can deliver to the target tissue, and then be released and allow the drug to bind. That's the tricky part. That's why drug-coated balloons in some ways are more complicated.
Thank you, Sahil. Sahil, you're going to hold yourself back and stay till the end because we'll have a lot more questions. I just want to take one point. I learned something very new that I'd never heard before, is the degree of inflammation and lipid content of the vessel affects drug delivery. Makes sense, never knew it. But you did make a point, which will be a great segue for Drew to take on, is that the debulking of calcium and vessel prep somehow improves delivery and clinical outcomes. And I think I will pass on to Drew. So translate biology into action for us that happens in the cath lab and take it away. So Drew Klein from Piedmont going to talk about vessel prep and optimizing drug delivery to the peripheral arteries.
Great,
Drew?
thanks, Subhash. I appreciate it. Let me go ahead and start sharing my screen. You guys see that okay?
Absolutely.
Perfect. I just want to say, Sahil, that's a great talk, and everyone, if please, I'm going to give you a reference here. Sahil's being modest, but there's an incredible reference about this, probably the best 16 pages that I read and then reread because I'm too slow because I'm just a dumb plumber, not a biomedical engineer. And so about this, it's a really complicated topic. And so thank you for the opportunity to present utilizing vessel prep to optimize DCB and DES, because I think there's a little bit out there about why we do vessel prep. I don't think we've ever perhaps thought about the science, and maybe with the science background that Sahil just gave, we can jump more into kind of clinically where it applies specifically for prepping the vessel. So what is vessel prep? Well, really it's kind of comes in three forms, either excisional atherectomy, that's removal of plaque. You're going to remove stuff to get a either a stent in or expansion. You're going to ablate maybe lipids in this case, or ablate calcium, and that's orbital atherectomy, rotational, maybe laser. And then of course there's vessel prep with sound energy with Shockwave. Let's see if there's data out there. So we've seen the basic science, and I'm going to kind of dip into where we're at currently with the data out there for vessel prep for drug, specifically for drug delivery, because I think atherectomy itself, though not to be used in every case, I think it does have applications in certain environments. And hopefully when it comes to vessel prep, specifically for barriers for drug delivery, we can talk a little bit more intelligently about why one might use it. And so why would you need to prep a vessel? Well, why would you not do it if you can't get the balloon to expand? If you have expansion of a stent, that's a problem. And as you looked at Sahil's slides, that you do wonder, here's an idea about why we have to get good expansion in the coronary literature, right? We have to worry about good expansion of your stents, and why we use IVUS for PCI. Well, why aren't we doing it in the periphery? What about removal of material that's difficult to treat? You might need to prep a vessel for anyone who has ISR or thrombus or calcium. And then, of course, atherectomy is sometimes used to limit stenting, or so-called no stent zones. And I think that's two reasons. A, to be able to come back later, maybe treat with new stents or new drug-coated material, or maybe down the road for biovascular scaffolds, so basically bioabsorbable scaffolds. And then I bring up the question, is preparation for drug? Is this a reason to prep, and why we need to do it? And I think it is. Let's talk a little bit about kind of some of the data that's out there, and just, when it comes to cases, I'm just going to show a couple cases where I use vessel prep for essentially drugs. So this is directional atherectomy, a heavily calcified long lesion that is quite a nasty, and this is the embolic protection device, and this is atherectomy, and then a drug-coated balloon to follow, and then some of the stuff. So really what you're looking at here is after you're really trying to remove calcium, remove long areas of atherosclerosis to be able to get drug to basically get into the vessel, and therefore hopefully decrease TLR. Here's another example of basically directional atherectomy for DCB. This is a very long lesion, right? So you can count this is a 250 millimeter lesion. This is hawking it, and then coming up with final, again, drug-coated balloon angioplasty following with no stent. So our ideal here is that by giving a bunch of drug in here, hopefully this will decrease TLR, but also we can always come back and deal with this later if need be, if the drug comes out. And obviously down the road, it'd be great to be able to have the drug stay in there even longer, and therefore decrease this even more, decrease clinically driven TLR even better. What about vessels that actually have a ton of something in there that you need to remove? Well, this is a case my colleague and friend Mitch Weinberg presented a couple years ago, and I borrowed it from him, of somebody who came in who had basically a standard run-of-the-mill SFA occlusion. He wound up putting in a whole bunch of stents from top to bottom, including some Sapere and a smart stent. over 400 millimeters of total stent. At that time, no DCB was available. Looks beautiful at the end, but any of us who do this every day, 400 millimeters of stent, something is going to re-narrow. And sure enough, there he comes back, and the patient comes back with recurrent symptoms 3 years later, and he brought the patient back for laser and then DCB. And so you can see here, we need to remove that intimal hyperplasia before the drug is going to take effect. You just do balloon angioplasty here alone, it's just not going to really work. And this is actually an on-site or on-label application for laser, and debulking this vessel is critical for not only delivery of the drug, but really getting luminal gain. And with that, I think you really see, there's the final picture there on the right, and I apologize, it jumped in the back. But that's going to tell you that it's important that we have to remove the intimal hyperplasia before we can actually get that drug in there. And this is a case that we've done recently of using Shockwave for vessel prep. And this is a common femoral lesion down at the right side. And you can see the critical heavy calcific lesions here. And then we treated with a Shockwave balloon, and then came back and treated with a 7.0 by 60 millimeter Admiral impact. And you can see a good result here at the end. The idea here was pre-treat it with sound energy, get the calcium to expand, prep the vessel, and then come back and hit it with a drug so that it's going to stay open for a long term. And you could see a pretty good result, and this patient's doing quite well post-procedure. So really, calcium, does that make a difference? And Sahil talked about this Fernelli's original paper here. This actually was a paper of 60 patients who got SFA disease and got DCB, and he divided it into 8 groups based on circumferential calcium on CT angiograms. So this is relatively novel. Look at the year here is 2014, and this was be the kind of the foray into this outside the lab and looking at length, but also was showed here that the higher degree of calcium, more circumferential calcium, the lower the drug effect was. You got more late lumen loss and more need for target lesion revascularization. You saw this exact slide. What this was is they divided up the on the CTA. Did you have this much arcuate calcium? Did you go 180 degrees, or did you get over 270? You get over 360, and as you see, as you get out to that 360 calcium, you're really seeing a lot of late lumen loss, and this is all directly proportional to the calcium. It's an inverse relationship between primary patency and late lumen loss. So let's take this into the clinical realm, all right? So you got this, you saw the basic science. Now you've seen the initial foray into the clinical realm. Definitive AR was the first kind of biggest study out there that looks at the outcomes. This was only 121 patients that got randomized, not severely calcified, to directional atherectomy plus DCB versus DCB alone. It was a 1-year follow-up. You can see the numbers are really low here at 41 and 50. There was a non-randomized arm of severely calcified lesions that went straight to directional atherectomy plus DCB. Again, only 20 patients in this. You can tell looking at the numbers here, this is not going to be powered to show any outcomes. So in over 102 patients, again, RCT lesion length reasonable, about 110 millimeters. Technical success was obviously more superior for directional atherectomy plus DCB, so you got more luminal gain, which is not surprising. But I think this also showed directional atherectomy for bailout stenting was extremely low, about 3.7%. And actually flow limiting dissections were very low amongst a directional atherectomy plus DCB arm versus DCB alone. So what did they show? Well, actually no real difference between these two different studies, DA plus DCB versus DCB. But again, it's underpowered to really show significant differences. This was the kind of first more kind of safety efficacy trial. And what we showed is that primary outcomes, the CD TLR, which I think is what really matters for the patient, was about the same, only about 7.3%, 8% for DCB. It'd be nice to see what the 2-year and 3-year outcomes of this down the road are. But duplex ultrasound patency is about the same, freedom from MACE about the same, and diameter stenosis about the same as well. So no difference, but again, look at the numbers here. These are relatively small. This was the first kind of proof of concept in a larger study showing that impact, maybe removal of calcium is going to make an impact on your efficacy of your DCB. Well, what was their take home is that lesion calcification and lesion length, interestingly, in the sub-study greater than a 10 centimeters were identified as potential predictors for superior outcomes for combination therapy. So I always laugh that when you look at the general trials for any SFA study, it's all less than 100. I'm still looking for those lesions. It always seems to be 250, 300 millimeter long lesions. And maybe that's because I live in the South, but regardless, they all seem to be pretty nasty lesions. And I think here, when you're talking about lesion calcification and lesion length also being predictive of recurrence down the road. So that brought us to the largest study that we have to date, the reality study, which looked at HAWK1 directional atherectomy followed by impact DCB, again, looking at primary patency at 12 months, and then freedom from MACE through 30 days. Again, low numbers, looked at 102 subjects. Now, this was an extremely hand-selected group of operators. I really wanted to be in this study, but I just wasn't on the cool kids list. This was an incredibly detailed group of the world's best experts of directional atherectomy. And I bring this up because if you look at the adverse events or the procedural complications, even the best experts in the world still had complications. This was 400 patients screened. Only 102 actually turned out to be eligible. There's your outcomes. So again, pretty small study all in all. Femoral popliteal lesions were real, 8 to 36 centimeters. Long chronic total occlusions greater than 100 were common. You had to have bilateral vessel wall calcification required in all lesions. And so, real severe calcific stenosis. There's a PAX or PAC-SS score. You can kind of go through this, what this means. This is Krishna Roka Singh's score, and I think you can do this on all your patients. It's pretty intense when you look at it, but that's a way of determining what I say is severe calcification is what you say is severe calcification. I think it's important because what somebody says may be not what we all agree on. So I think it's important to have some sort of scoring system so you can grade this, especially in clinical trials. So again, these were tough lesions. If you look at lesion length and reported bilateral calcium, the reality study really was out in the far right. Longest lesions with the heaviest amount of calcium when you compare it to a bunch of clinical trials also in this space. And what they showed, again, was that the perforation rate, and I think this is important, in the best of the best, 3.1% dissection grades. This is distal embolization, 12.8%. I just did a hawk the other day, and sure enough, distal embolization happened. So you got to be ready for it. Provisional stenting, about 8.8%. So I think it's important to understand that atherectomy can cause issues, and this is with the best of the best. If you look at the primary efficacy or 12-month patency rates, about 76%. Freedom TLR, a little bit better. And this is the kind of take home from that, is that bilateral calcium was present in 86% of lesions, 180 centimeters, that's real life, 39% CTOs. Outcome freedom from CD-TLR at 1 year was 92.6%, patency about 76%. And I think what a lot of us believe is that not laying down a bunch of metal is a good thing, an 8.8% bailout stent rate. But again, remember who's doing this. This is the best of the best, hand-selected operators, and actually not that many of them. So what about Shockwave? Do we have any data there? Well, there's the PAD series, PA3, Disrupt PAD, and this largest RCT of calcified lesions that we know about. This is pre-procedure IVL or PTA, and then post-treatment with a DCB and/or stent, looking at the outcomes of procedural success, which is a pretty weak out point, but it is what it is. Secondary outcomes about MACE or CD-TLR. And what this showed in 306 lesions, 86% showing part calcification. Indeed, just for treatment success, and all of us that use this, obviously will tell you that the IVL works really well for expansion. I think that's important. And the take home, as published here just recently by Tepe et al., the 30-day outcomes from this randomized controlled trial show indeed that you improve procedural success in calcified lesions using intravascular lithoplasty lithotripsy compared to just regular balloon angioplasty. And again, this is just 30 days, so we don't have long-term. We'll see that within the next couple years. And again, the dissection rates are relatively low as well. kind of owing to the fact that we know in most of these, we're only going up to about 4 at max, maybe 6 atmospheres, while with regular balloons, to be able to crack the lesions, you may be going higher. So indeed, across the board, if you look at the data to date, is a decrease in 44% lower pressure, again, leading to dissections, less stent placement, less need for post-dilatation after LVL, and we hope that long-term that will make a difference in terms of outcomes, but stay tuned. There's an observational study also just recently revealed at Viva by Aaron Armstrong, and that looked at the first 752 patients using IVL. And this showed this is basically all comers, and the 752 patients, again, real lesions, 32%, and need for embolic protection was only about 1%, which I think is good. Distal emboli, 0. So again, safe and effective, and another way to prep your vessels before going with your drug. So just a little bit of note on prep to go back. I'm starting to date myself here, is that not a lot of people know what these pictures are. But if you look at the Berlin Wall for calcium, lesion length, thrombus, and ISR, you really got to break it down. And then, however, there's a little note on prep. You got to worry about cost. These things are not cheap. These devices are not inexpensive. Distal embolization is a risk, except for maybe with IVL. And vessel perforation is an issue. It happens across the board. Doesn't matter if it's IVL or Hawk or any of them. I think it's important to realize that those things can happen. But clearly, prepping the vessel helps deliver the drug when barriers exist. And your barriers that you really need to worry about are calcium, lesion length, your thrombus, and your ISR. With that, I'll say thank you very much. I look forward to seeing everybody here in Atlanta for May of 2022 Sky Scientific Sessions. And with that, I'll stop and turn it back to you guys. Thank you.
Drew, thank you. I wouldn't mind if my co-panelists jump in with questions, but I do have one before we move to Alyssa. Is that, Drew, how do you, just for the audience, break it down, how do you decide when to debulk? So do you look at a CT-based calcium, you have a CT scan, or you look at fluoroscopic calcium when you're getting access or imaging the vessel, or you do IVUS and you differentiate between intimal and deep wall, and some people even use OCT. I don't, but for peripheral arteries, for SFA and femoral popliteal, how do you decide?
Great question, Sebastian. I actually have to credit you with this. I think I've started using more IVUS, real time. It's an old adage. What do I do in the coronaries? I don't do a single coronary PCI without IVUS. Why am I doing it in the periphery? Faster, time, cheaper, get the information. And if it's concentric 360-degree arc of calcification, it's going to help decide where I'm going. If it's eccentric, I'm probably going to go directional. If it's 360, I'm going IVL, or, if we have a CT, it's great. I can click through the CT. I still am using much more IVUS now than I ever have before. And I'll throw a prediction out there is I think just like now we use ultrasound access, right, for everything. I think fast forward 10 years, I think we'll all be using IVUS for all peripheral interventions as well as coronaries or something similar, some sort of imaging, because I think you need to see in 3 dimensions. We are working in 2 dimensions. I think we need to really see in 3 dimensions to be able to optimally treat our patients.
Sahil and Alyssa, just a quick, fast response. Sahil, you first. How do you decide? And then Alyssa.
Yeah, so we use clues about calcification density, and the devil really is in the details. If it's concentric and it doesn't expand easily, then I think using vessel prep techniques makes sense for the aforementioned reasons. So one easy way to do that is to try to dilate with a 1-to-1 balloon at low pressure. And if you can relatively easily without a waste, then you probably are okay. If you can't without a severe waste or trying to go to high pressures, then it probably behooves you before you dissect the vessel to consider an alternate approach.
Alyssa, any magic tricks from you?
So I also like to look at the angiogram before it fills with contrast, because I think you get a lot of information from the pattern of the calcium on the plain film, essentially. So, the railroad train track kind of calcification is really medial calcification and often doesn't correlate at all to any meaningful intimal calcium or flow limiting calcium. And sometimes you can see, the nuggets of calcium, and those are the ones that really concern me. Those are often, at the adductor canal, at the site of the initiation of the SFA CTO, or along the vessel. And those are the places where I worry that you need to do some sort of advanced therapy there.
Thank you. I'm going to move on to Alyssa, and before I invite my dear colleague to present, she's going to talk about a difficult subset of lesions, and her topic is so broad, both femoral popliteal and below the knee. While she shares, we actually discussed about it, and I think she's going to have I'm looking forward to her talk, because what we asked her to do is share her thoughts and talk, if possible, about successes and failures. I think that's what is going to get us all excited and ask her a lot more questions. So, Alyssa, please take it away. I'm really happy and delighted that you're able to join us.
Thank you, and thank you for the invitation to speak. I'm going to review two cases. So the first will be a femoral popliteal case of a claudicant who had failed optimal medical therapy and supervised exercise therapy. And the second patient will be a patient with isolated below the knee disease who has a wound. So our first patient is a 76-year-old man with CAD who's had PCI to his RCA and OM. He has diabetes, hypertension, hyperlipidemia, AFib on a DOAC, history of spinal stenosis, and bilateral SFA stenting in 2014. So the history of that was that he presented with claudication, and on the right, he was found to have a high-grade calcific long femoral popliteal disease, and he got jetstream atherectomy. And as Drew noted, he had that procedure complicated by perforation that was sealed with balloon angioplasty and covered with an EPIC 6x1 20 millimeter stent. I'll show you those angiograms. And on the left, he had a focal distal high-grade SFA stenosis and got a 6x 100 millimeter life stent at that time. So a few years later, he was complaining of increasing anterior thigh pain, but paradoxically, the left was worse than the right. And as you can see, the ABIs are much worse on the right. So at rest, I think this is really instructive. At rest, both of his ABIs were normal, but after 2 minutes of exertion, the right dropped to 0.35 and the left was 0.96. So on angiogram, he was actually found to have some non-obstructive calcified lesions in the left SFA, and the stent was patent. So we thought at that time that it was more the spinal stenosis playing a role in that left leg pain. However, now that he felt like he was safe to walk some more, he walked longer and harder, and then started having right more than left claudication, and was found to have distal stent edge restenosis that was treated with a drug-eluting balloon at that time. So he represented in 2020 with increasing claudication. At that time, he was on apixaban, Plavix, high-dose statin, and NACE inhibitor. His physical exam was notable for a weak right popliteal pulse that was monophasic by Doppler, and his right DP and PT were monophasic as well. His ABI had come down from 1 to now 0.77 on the right. Interestingly, his left ABI was worse, but his right symptoms were worse. So he was referred for supervised exercise therapy. We put him on a treadmill before that. He was able to accomplish 4.5 minutes of modified Bruce protocol, total 3.4 METs. He started having pain at 40 seconds of exercise and had calf pain radiating to his buttocks bilaterally. He did go to supervised exercise therapy, although he quit after 2 sessions because of the pain. And the right leg was limiting him. So at that point, we brought him for angiography. So just want to review the initial procedure he had in 2014. So he had a very short focal SFA CTO. And you can see that following jetstream and balloon angioplasty, there was a contained perforation here. that was sealed after a long balloon inflation and then covered with this bare metal stent. And you can see the intravascular and extravascular path of this stent. So when he returned for worsening symptoms earlier this year, he had continued patent iliac system. His right common femoral and profundo were great. And here's a good example of these nuggets of calcium all the way down the SFA into the areas of CTO. So prox to the stent, he had a short segment CTO. You can see that this stent has become even more curvy, sort of speaking to the interesting anatomy and torsion that the SFA faces, and sometimes why stenting can fail in these areas. And then distal to the stent in the area that he had previously had the drug-eluting balloon in 2017, had developed a longer CTO that reconstituted just at the adductor canal. He had very minimal tibial runoff, the AT down to the ankle. So we crossed the lesion with a Fielder FC in a Corsair microcatheter, and had decided that we were going to take a Shockwave balloon all along this segment because of the heavy calcification. Interestingly, the Shockwave balloon wouldn't cross down to the distal SFA P1 segment. So we did some inflations all along the way that we could. And because the Shockwave balloon wouldn't pass, we decided to dilate the P1 and distal SFA with a 2x40 millimeter balloon just to make some space. And with that, we were able to deliver the Shockwave, and we treated the P1 distal SFA region, the distal SFA within the stent, and up into the mid SFA. We were concerned for the haziness here in the distal outflow of the pre-existing stent, and we treated with a 4x40 drug-eluting balloon. Despite that, there was still persistent haziness. So we put a short 5x30 millimeter drug-eluting stent overlapping the prior stent and avoiding the popliteal segment there. And you can see reasonable result outflow from this stent. There's still these pockets of calcium all throughout the SFA, and you can see this nubbin of the intraluminal vessel from the first procedure. There's some disease in the popliteal, good geniculate collaterals, and improved outflow into the AT and down into the foot. So we discharged him on Plavix and apixaban for 3 months, and with a plan to switch to Plavix. Just Plavix and apixaban for 3 months, and then stop the Plavix at that point. This is interesting. So 3 days after he had the Shockwave lithotripsy, he started complaining of right thigh pain with swelling and redness, and came to the ED. He had this erythematous macular-papular rash, essentially right over the area that we Shockwave, and it came across over the right buttock. They sent him for a CTA, and thankfully showed that the FemPop stent was patent. But that rash was zoster through and through, and he was confirmed VZV positive by PCR. So, I don't know if the Shockwave activated zoster in the dermatome there, but it was an interesting finding. So after that, he completed supervised exercise therapy, did a lot better. Got himself up to 9 minutes on a modified Bruce post supervised exercise therapy. He continues to work in the yard 3 to 4 days a week and walks with his wife in the neighborhood 30 to 40 minutes a day. So we're going to move on to below the knee disease, where I'd argue there's less role for drug-eluting therapies. So this is a 76-year-old man who has CAD, has had a CABG and a surgical AVR. He has diabetes, and he had a fall and a tibial plateau fracture and a resultant left lower extremity DVT. And while he was in rehab recovering from all this, developed a left heel ulceration that was non-healing. He was on aspirin, statin, rivaroxaban, and lisinopril. He notably had very impressive edema bilaterally, and the left greater than the right. He had chronic venous stasis changes with hyperpigmentation, and the open wound of the left heel with drainage that was 2 inches in diameter. His pulses were significant for good, strong femorals bilaterally. A 1+ pop on the right, non-palpable on the left. Right DP and PT were biphasic bilaterally, and the left PT was biphasic and the DP was absent. So on the diagnostic angiography, you can see his iliac inflow is patent. His common femorals are patent. And on the left lower extremity runoff, there's a patent profunda, patent prox SFA, some disease into the popliteal, P2, P3 popliteal, and not flow limiting, but worth noting. And you can see as a totally occluded AT and a PT that brings runoff into the foot. So in this case, because of his heel ulceration and this chronic nature of this wound, we decided to do rather complete revascularization. So first started by wiring antegrade into the AT and retrograde back into the PT with a fielder and a Caravel support catheter. So you can see the wire coming down the AT here and crossing retrograde into the PT. We ballooned into the pedal loop with a 2x40 over the wire balloon, and then back into the AT at the ankle with a 2.5x100. And then I used IVUS to size because these vessels looked rather large. And so used a 4x20 millimeter balloon for the proximal AT. After that, we went after the perineal, wired it antegrade into the ankle and ballooned with a 3x100 millimeter balloon. And you can see here the final angiograms. So we had the same good runoff from the PT, improved flow into the perineal, and a patent AT. And this is his runoff into the foot with good flow into the pedal loop. So, you know, his wound healed within a few weeks, and he's been doing really well. So the question is, for below the knee, what are some options that we have? So, you know, balloon angioplasty, we know is not great, but I think at this point, that and some calcium modification are what we have. The data for DCB, as we know, fall short. So both DES and DEB fall short. So that from the IMPACT DEEP trial, we know that it failed to meet the primary superiority endpoint compared to balloon angioplasty alone. And there was a numeric trend towards more amputation. In the BioLux P2 study, it did fail to meet the primary endpoint, but there were no safety concerns. And in the Lutonix IDE pivotal study, they reported the results out to 6 months that were non-significant, but showed a benefit of DCB over PTA, but out to 12 months, at a year, they were basically the same. And then a numeric but non-statistically significant trend towards improved outcomes with the standard PTA. So because of this, the FDA denied approval for Lutonix below the knee. But as Hill mentioned, there's a new kid on the block, the Limus DEBs, and there's 3 devices, at least 3 devices designated as FDA breakthrough devices: the Magic Touch balloon, the Virtue sirolimus eluting balloon, and the Solution sirolimus eluting balloon. What about drug-eluting stents? So drug-eluting coronary stents, there are some studies looking at randomized trials looking at DES versus PTA or DEB or BMS, and you can see them listed here. And in general, treatment with DES has improved primary patency at 12 months. And having that scaffold there can address some of the acute recoil and the problems that we face with balloon angioplasty alone. However, the problem is that long, small stents in below the knee vessels are not a great idea. I would reserve them only for securing the inflow into the tibials. So it's really, we're hopeful here that the Saval stent, which is the Alluvia BTK, which is a nitinol self-expanding stent, and this is the drug-eluting stent that Sahil was mentioning, may help in below the knee disease. And so there's a superiority trial to PTA and infrapopliteal disease in patients with CLI that hopefully we'll get results on that'll be helpful to patients with CLI. And then finally, the bioabsorbable scaffold. And the Life BTK study is upcoming, looking at the Esprit bioresorbable stent with a drug coating. And it's everolimus drug with a PDLLA controlled drug release scaffold coating for controlled sustained drug release. So although we may not have current options for drug-eluting therapies below the knee, hopefully they will be coming. Thanks very much.
Thank you, Alyssa. You know, we have 8 minutes, and I'm going to ask a few provocative questions and then answer our chat. Sahil, would you like to take the Q&A question first, and so we can
Sure.
answer that?
Yeah, sir. The chat question is quote, I usually reserve lithoplasty for calcific iliacs where perforation risk is significant. When should I do lithoplasty for infrainguinal arteries? Is there data showing improved outcomes? So to sort of answer that, I think that the question really is, when do you need to use calcium modification, and what would be the predictors that would suggest that plaque modification will help you get good vessel expansion? I think increasingly there's been data presented that with DCBs and DES, but especially with DCBs, that getting a bigger lumen will probably improve your long-term outcomes with respect to patency. And there was some data presented at TCT this year looking at the IMPACT DCB family of trials that suggested that. So I would say that for the infrainguinal space, as Drew pointed out earlier, it's very safe. There's no embolic risk, really, very little in the way of perforation. And so I think it's reasonable to consider it where you might think of an alternate drug or a plaque modification technique that's either atheroablative or some other, more injurious technique. I think that the barrier of reimbursement is about to be lifted, and that obviously will help. Your hospital administrator won't get on your back as much about the use of this technology. And so I think there will be a significant increase in share and clinical application.
Thank you. Alyssa, I really like the cases you shared, because you shared the types of cases that frustrate us, and sometimes we don't want to see many of these in a month. However, those are the realities where these technologies still have a limitation. So I appreciate you doing that. I want to ask you a prediction question, which are the fun, most hardest, but we can go back to this webcast and see what happens. So your prediction that below the knee DCBs don't work because there is a drug residence problem or bioavailability problem, and somehow switching to sirolimus would solve the bioavailability problem, especially based on the use of spacers, enhancers, phospholipid encapsulations, and nanoparticles that Sahil talked about. So do you essentially think this is a drug delivery and bioavailability of the drug, and hence moving to a different formulation is going to help that? First, yes, no, like on CNN, don't be afraid to get it wrong. We are among friends. And then we'll go out to Drew and then finally to Sahil for the word of wisdom. Go ahead. That's a difficult question, I know, but make a prediction.
I'm going to say more than yes, no. I'm going to say no to drug-eluting balloons because I think there is more to wound healing than we think. So if we're looking for a good angiographic response, there may be a role for it, but if we're looking for wound healing, it may be more complicated than we think.
That is a
Distal
typical
embolization.
Connecticut answer. I wanted a Georgia answer, yes, no, and I'm kidding. But you're right, and I think that you have cited data to support that. So we'll get back to you if time permitting. Drew, your prediction and your candid Piedmont answer?
My candid Georgia answer is I'll be a purple state and guess in the middle, yes and no. But I'm going to go with the fact that I think what we're dealing with here in the coronaries, again, going back to what Sahil mentioned, you have smaller vessels here. So I think one of the things that we ran into is I think we classically undersize our vessels here, BTK. Below the knee for me, I'm always using IVUS. I think we need to be able to make sure we treat the vessels appropriate size. I think bioabsorbable stents with drug coating is going to be the way to go. I think we're going to do just like we're seeing now with drug-coated balloons for coronary restenosis. I think you're going to see the same thing in the BTK. I think it's going to work.
Sahil, your question, I'm going to complicate this question a little bit more for you because you know amongst us best about this. So the drug delivery issue of paclitaxel was solved using hydrophilic excipients. Now, you suggested few mechanisms, few pathways, how the drug bioavailability of the sirolimus is going to be solved. Do you think that it is going to help us solve or address the BTK answer? Or do you think that it is just a different formulation? And the broader question is, why even think of sirolimus? I mean, I think that's the kind of philosophical question that I want to leave the audience with. So your 2 cents.
Sure. So the impetus for using limus agents is really the coronary DES data that Alyssa showed. The late loss and the clinical efficacy that was seen with those devices was strong. Although there are paclitaxel-eluting stent data, the PADI studies that were not shown, that also show similar efficacy. Now, if you take, for example, the data for a Xience everolimus-eluting stent below the knee in a mostly diabetic substrate from one of those trials, the amount of late loss that was seen was 4 times that which was seen for coronary intervention with the same stent in the same patient population. So the biology of drug elution and uptake and response to injury is different in the below knee arteries than it is in the coronaries. So I think the drugs work. I'm bullish about drug delivery, both for improvement of long-term patency and ultimate healing. But I think that it's the formulation and the residence time of the drug that matters. And so the longer we leave drug there, the better. And I think that we will figure that out over the next few years.
I want to add just my complete, uninformed, unsubstantiated comment. Just from looking at the registry data we have about 6,000 core lab angiographic analysis. And I can tell you my own practice and what I see in the registry that we use undersizing of below the knee arteries in a big way. So I think the way we prep vessels in the femoropopliteal, common femoral, I saw the common femoral case Drew saw, he used a 7 or 8 millimeter balloon, just looking at the size of it. And I think I routinely undersize. I mean, I use 3A, sometimes I use 2.5, 3.0. I mean, I never go 4 or 5s. And I think that we may have to learn a slightly better preparation of vessel and better angioplasty, something very basic that I think drug-coated technologies and atherectomy in the femoropopliteal areas have taught us. So that's my completely, I would say, off-the-cuff remark. And I just want to hear, what do you guys think? This is something tangible or this is completely goofy?
I think we again, kind of from your prior presentations I've listened to, I think there's 2 things that's very clear. I think when you take the same stent and put it in 4 different vascular beds and it gives you 4 different restenosis rates, clearly different differential biology. I cannot disagree or cannot agree more with Sahil when it comes to that. And then number 2, I think just how we do things. I mean, we below in the periphery classically use our eye instead of using some sort of imaging. And I think we probably need to translate that.
Elisa, do you feel you undersize, or this is just my personal bias?
So I'm aware of undersizing, and when I try to do at least a 3.5 in tibials until close to the ankle. And then if I feel that it's bigger than that, I'll IVUS before I use a 4.
Sahil, any plans you think where CRF could enlighten us with a study where appropriate sizing and simple techniques that can have a widespread, imagine we use good technique and good processes and we improve outcomes without really relying always on some very expensive technology and go back to the basics. Do you think, is there a way that we could learn more from that experience?
Well, I think we need to take your core lab angiography and put it through some AI algorithms and figure out how we can predict sizing. More importantly, though, in the present, I think the only way to really know is to use IVUS. So, I'm the PI of a below-knee scaffold trial. In the training phase for that trial, we've done a bunch of training with physician operators, and they habitually undersize, even experienced operators habitually undersized balloons. And it's only with the use of intravascular imaging that we can get close to good correlation of 1-to-1 vessel sizing with intervention. So unfortunately, in the present day, without science fiction, we really need to use IVUS or some other intravascular technique.
Thank you. Thank you, Elisa, Drew, and Sahil for this perfect hour. I hope our audience has enjoyed it. And I can tell you that I go back to my introduction that these are the kind of topics that CVI wants to bring. And so that in this day and age, when we are inundated with webinars, the presenters and those who are presented to both have an enlightened experience. So I can't thank you both, ladies and gentlemen, for making these wonderful presentations. I know you guys have very, very busy schedules. You live in the cath lab, but sharing your experience and the wisdom and getting to see some old time pictures was a real treat. So Drew, next time when you get invited to CVI webinar, pick up a picture. Elisa, don't be shy. Show some pictures from Georgia. We'll love to see them. But anyway, I thank the audience for constantly supporting CVI and also looking forward to see you all on July 21st to 23rd in a live CVI event in Denver, Colorado. So thank you, gentlemen and ladies, for joining us tonight. Bye-bye.